Welcome to this special edition of HRS TV this evening. I'm delighted to welcome a stellar group of colleagues to discuss the important recent Boston Scientific Advisory. First of all, I'd like to welcome Dr. Mina Chung, President of the Heart Rhythm Society and Cleveland Clinic physician, Dr. Amit Shanker, Chair of the Health Policy and Regulatory Affairs Committee and physician at Rochester Regional Health, and Dr. Molly Sachdev, Vice Chair of the Health Policy and Regulatory Affairs Committee and physician at WashU. Welcome, everybody.
Thank you, Oliver.
Yeah. Perhaps we could kick things off by asking one of you to give a brief overview of the issue with the RELIANCE G ICD leads and what particularly has prompted this safety advisory.
Thank you very much. I can go ahead and do that. And I want to thank also Amit and Molly here, who have really led the charge in figuring this very complex advisory out. It took us 10 to 14 days, almost 2 weeks, to try to understand this well enough to be able to help interpret it for our members. So the issue is that the RELIANCE Gore-coated, ePTFE-coated leads can develop calcification over the Gore coating. The Gore coating is on the shock coils, and this has been, in some cases, associated with a gradual rise in the daily subthreshold low voltage shock lead impedance, or LVSI. This gradual rise in impedance can reduce the shock efficacy. And if the high voltage shock impedance gets to be greater than 145 ohms, then the first biphasic shock phase is truncated to 20 milliseconds, and that leads essentially to a monophasic shock and a potentially lower shock efficacy. It also triggers a high voltage shock impedance alert called code 1005 that's seen afterwards. There have been failed shocks that have been reported, and the initial estimates were that about 10 deaths could be attributed to failure to convert a sustained ventricular arrhythmia from this phenomenon over the past 10 years, and this is from Latitude data. There have also, however, been deaths reported due to extraction. Because the Gore coating doesn't really cover the pace sense leads as much, the pacing and sensing are not known to be compromised. So here on the bottom, you see some of the calcification built up. And then this is an example of the gradual rise of impedance. This is due to a shock that occurred, and you get a transient decrease in impedance, but then it also starts rising again. So Boston Scientific, to their credit, did a very deep dive on this once they learned about the issue from an event that occurred where this code 1005 came up. And they, on doing this, developed some criteria for gradual rise in low voltage shock impedance. It's based on 28-day averages, essentially kind of visually looking at the last 28 days of data, and defined it as a 20 ohm rise from baseline occurring at least 3 years post-implant, because earlier in right after implant you can get some increase in impedance, and to a minimum of 90 ohms for single coil leads and 70 ohms for dual coil leads. And it also excludes rises in excess of 30 ohms per quarter, because if you get a very rapid rise, then it should trigger you to look at some other cause for the increased rise, like a conductor failure. For comparison, the average low voltage shock impedance for non-gradually rising leads is about 72 ohms for a single coil and 47.5 ohms for dual coil leads. Now, what's the scope of this? The impacted leads, these are leads that were implanted from 2002 to 2021. The RELIANCE ePTFE leads are no longer available, but about 354,000 leads remain in service, and 250,000 of those are in the US. Boston Scientific estimated that the potential for life-threatening harm due to arrhythmic death in all patients with these ePTFE leads is at 0.0021%, or 1 in 47,500 leads at 10 years. Now, the if you look at the rise in impedance at 10 years, approximately 6.4% of ePTFE leads will meet the criteria for this gradual rise at 10 years. And of these, 8.9% will have been at a low voltage shock impedance greater than or equal to 150 ohms. So that gives you an idea as to what the incidence or prevalence is of this problem. Now, it turns out that doing a DFT or shock test is not recommended to assess your high voltage shock impedance because, as you see from this graph, the low voltage shock impedance can be lower immediately after a shock, but then again rise, so it can give you a false sense of security. And also, the shock success at DFT testing is not predictive of future success in the setting of this ongoing lead calcification. So this rise after a shock gets up to the previous levels and continues to increase by about 4.2 months for single coil and 5.7 months for dual coil leads. Now, it also turns out that there is a polarity bias. In systems that show a gradual rise, reversed polarity, which is RV coil positive, was 4.5 times more likely to initiate a post-shock fault code. Now, you may recall that this Boston Scientific lead, the initial default polarity was RV coil negative, but some devices may be programmed with reverse polarity. And those systems programmed to reverse polarity have a lower shock success rate. So here's a figure showing initial polarity where the RV coil is the cathode or it's negative. And then here's reverse polarity where the RV coil is positive. If the device is unable to convert the arrhythmia, it automatically switches the polarity for the last shock within each zone. So your last shock could be reverse polarity, even though it was programmed initial polarity. This slide shows the impact that this has. So on this left graph is a graph of initial episode success, initial shock success in gray versus episode shock success. And this is with the initial polarity. So you can see that as the impedance goes up, that you do get a decrease in initial shock success, but that the overall episode success actually stays fairly high until you get to greater than 150 ohms. In reverse polarity, there are fewer of these devices, this programming around, so the confidence levels are greater, but you see that the initial shock polarity at 125 ohms is much lower, and also episode shock polarity is lower as well at 125 ohms. So the recommendations are that there should be doesn't have to be changes to the scheduled follow-up interval for people with these leads because this rise is gradual. You can continue routine follow-up. But during follow-up, you should determine the most recent 28-day average low voltage shock impedance and review the high voltage shock impedances for shock since the last system check. And if the lead does reach greater than 70 ohms for dual chamber and greater than 90 ohms for single chamber and have this rising shock, the rising impedance pattern, you should program to initial polarity and max output shocks. And if the low voltage shock impedance is greater than or equal to 150, then based on this likelihood of the code 1005 alert and the reduced shock success, consider lead replacement. And if you do get a shock, then consider lead replacement. So I just want to show you the Boston Scientific recommendations that are in their safety advisory. Again, and this is to clarify this. They had said that you program to initial shock polarity and all shocks to maximum energy if they have this rising response in a greater than 90 ohm and 70 ohm impedance. And this this figure 1 is the figure that I just showed you. We try to clarify this a little more for you in our HRS recommendations. We do recommend that all patients should be followed by remote monitoring, if at all possible, and that you have a low threshold to discuss with Boston Scientific Tech Services, because they can pull out additional data on these leads, including the pattern, including whether or not potentially it's a SVC coil or RV coil. And all patients with gradual low voltage shock impedance rise consistent with these lead calcifications should program shock polarity, the initial RV negative polarity with maximum shocks. If you're unable to program to the initial RV negative configuration and you've reached greater than 70 ohms for a dual chamber, greater than 90 ohms for a single coil, start discussing with your patient the potential for lead replacement if it continues to rise, and discuss again with the Tachy Tech Services. Strongly consider lead replacement if it reaches greater than 150 ohms in either polarity, or if you do get that code 1005 alert. Should consider the risks and benefits of lead extraction versus abandonment, the risks with abandonment, the potential increased risk with calcified leads, as well as the timing of this with longer lead dwell times if you put off extraction, but also consider alternative strategies like a non-vascular ICD or addition of a lead. We also note that financial assistance may be available with limited lifetime warranty. Molly, do you want to talk about the MOD database?
Yeah, thanks, Mina. So, I think the interesting thing about this safety alert and many of the safety alerts that we deal with at HRS is that these alerts really come to light because of the partnership between physicians, HRS, and the device companies. In the sense that, the whole reason we know about this is because physicians noticed that there was a problem with these leads. They reported this problem both to Boston Scientific and to the FDA, and that's actually what prompted the company to take such a deep dive into what was going on. And that's how we know, even though these leads are no longer being manufactured, they're no longer on the market, that's how we know that this problem exists, and that's how we know how to advise physicians and advise patients on what to do about it. And so I just wanted to take a moment to talk about how that process works, and really to talk about sort of that a lot of these alerts, it really just comes down to physicians reporting it both to the FDA, and the FDA has this MOD database, and to the company, so that we could then act on it.
Thank you.
And here's the information there. Yeah.
Right, so you can read the full alert from HRS with this link, and you can there's also a link to the physician letter. I'm going to stop sharing there and take some questions.
That's wonderful, Dr. Chung. Thanks so much for crystallizing the salient points regarding this advisory. Perhaps I could start out by asking you, how significant is the risk to patients who have this lead implanted? I know that you had quoted some numbers about patients who have been affected adversely by this problem. But I'm also aware of some more recent news reports that quote higher numbers of patients affected. Do we have a clear idea as to the adverse events that have occurred as a consequence of this particular characteristic of this lead?
I know there was a news report recently about 16 deaths and a number of injuries. We're going to learn more about this as time goes on. I do want to make one other point, though. These leads have actually pretty long longevity in the industry, and perhaps that is it's a good and a bad thing in that we're starting to see calcification. But I remember Bruce Wilcoff telling us that with implanted devices, we're almost lucky that we have battery voltage, that the battery goes down and you replace the device, and you avoid getting to the point where you have random component failures. So this is, in one respect, you can look at this, yeah, this is really upsetting that this happens, but on the other hand, it's a reflection of the leads lasting a longer time, and also perhaps we're fortunate. The silver lining is that this is a slowly developing phenomenon, and it's something you can follow. We have some parameters at which you should consider replacing. And before that, we haven't really had such signals for when a lead might be going bad.
That's great.
And I think people should.
Sorry, please. No, go ahead, Dr. Sachdev.
I was thinking, I think the other point too is that it takes a while for these leads to get to a point where you start to see this calcification process. 8 years before you really even start to see it. And then in that process, it's only a very, like Mina showed us a very nice graph that shows you that it's really only a very small percentage of these patients that get to the 150 ohm mark where you need to replace the leads. And so I think we need to put all of that in context.
Completely agree. You'd mentioned the risk of extracting old leads that get calcified, and I spend a lot of time battling calcification in old leads. Is there any evidence that this family of leads is more prone to calcification and more difficult extraction than any of the other old or similarly aged ICD leads that we have to deal with?
It's a really interesting question, because we put in a lot of these leads in young patients, and because the perception was that the Gore coated leads were easier to extract because of the coating, and you didn't have fibrous ingrowth into the coils. So we'd actually done a study a long time ago looking at the recalled leads, and which were the ease of extractability, and just using fluoro or cine time as a surrogate. It seemed like the Gore leads actually came out a little easier, and the leads that had backfill to the surface of the coil were a little easier. There's some more recent data that my colleagues at Cleveland Clinic published a few years ago, and showed that the Boston Scientific, acute complications or serious complication rate was pretty similar to the other leads. But we will see these leads are going to be older. They're going to have longer dwell time and calcification. If it's calcified on that SVC area, it may be a little more difficult. But some of this also may be more uniformly distributed along the coil. It's going to be hard to know, and we're going to want to probably track that to see whether or not it is harder. But we have heard of some deaths that occurred due to extraction of the leads.
Yes, sounds like we've still got a lot to learn on that regard. Just going back to sort of advice that can help physicians on the ground. Just to clarify the point, for patients who are asymptomatic and showing normal function with one of these leads in, should physicians consider replacing the lead or just continue monitoring?
Amit, do you want to?
Sure. I mean, the current data does not suggest routine replacement of the lead. Of the leads that they have tracked, only 6.4% will hit that behavior of the gradual impedance rise, and of those 6.4%, only 8.9% they project will eventually hit greater than 150 ohms, which is roughly 0.6%. So at this point, the data does not suggest routine replacement of the lead in that context.
Well, that was like at 10 years, right? So at 10 years, they will have that 8.9% of 6.4% will have hit 150. Yeah.
Do you have any special advice for physicians who have a patient come into a routine generator change, though, with one of these leads in place? Is there specific advice that we can give to physicians about that?
I think that's a great question that we've sort of thought about. I think it'll depend on where the lead is at the time of generator change. And I think it's one of those things where you have to think of all the factors and you have to be involved in shared decision making with the patient. In the sense that if you have a lead that maybe is showing this gradual rise phenomena, but is not anywhere near the 150 ohms, and you look at the patient and you say to yourself, well, I don't know how much more time they have left either, then maybe that would be a patient that you don't do anything for. Whereas if you see somebody who is sort of closer to the 150 ohms, they're maybe younger, then that may be somebody that you might want to consider either replacement or extraction or however you want to handle it. But I think the bottom line is it'll depend on looking at the whole patient, looking at where the lead is and if it within the gradual rise phenomena. And I also would suggest maintaining a very low threshold for calling TACI technical services, because here's the thing that they've done a great job. We've got a lot of data, but the data can be it's pretty complex. And so talking to them would be probably a very good initial step to get a better sense of where we are in this process, and also understand that some of this data is going to be evolving with time. And so we may know more a year or two from now than we do right now. All the more reason to make sure that if you're considering doing something with the lead, whether it be replacement or extraction or whatever the case may be, maintain a very low threshold for talking to people who have that data and can help you decide what to do along with your patient.
And if I may just,
sorry,
just further clarify, the data that we presented today is strictly product performance data that was obtained from Latitude. So these are Boston Scientific only systems. We don't really have a good sense of impedance cutoffs and trends in mixed systems. We do intend to have a meeting with other manufacturers as well. That Boston Scientific actually asked us to oversee, HRS that is, to determine how do we collect that data to really follow the behavior of those leads in the mixed system configuration. The other thing to consider is we do have a fair amount of product performance data, but it seems that the clinical adverse clinical events, that data is just starting to emerge. So I think absent getting more data, it's going to be difficult to give real clear guidance in that context, but that might evolve. Sorry, I didn't mean to interrupt.
Not at all. I think that's a wonderful point about mixed systems that you make. So lots of things to factor into the equation. It's good to know that there's help out there from Boston Scientific Technical Services. I think, Dr. Sachdev, you had touched on this. How should we as clinicians approach patient communication around this issue, and how are you guys going about shared decision making around this advisory?
To me, obviously it'll depend on your patient and the relationship you have with your patient, but I think we just be upfront about it and say, you have a device that has a wire or a lead that is on advisory, and there is a concern that this lead could have a phenomena that happens to it that may result in it not being able to defibrillate you. But the actual incidence of this is extremely low. It's not that high. We're going to follow you closely, and we're going to see where you are and if it's actually a concern for you, because it's only really a small number of patients, like, Amit had said that Mina should have shown us a picture of, that actually exhibit this phenomena. And even a smaller number of those patients get to a point where you're going to see a difference in terms of initial shock success or episode success. So I think the messaging should be that, yes, this is a problem. Yes, we're aware of it. Yes, we are following it. But let's not be hasty and just go out there and replace everybody or go out there and extract everybody, because that's definitely not what we want to be doing.
How are you actually having that conversation with your patients? Are you sending them a letter? Do you involve your risk management team at in your medical facility to help draft that letter, or are you actually bringing the patient into device clinic to have that to have that conversation face to face?
Well, at our institution, we're sending a letter, and it's probably not a bad idea to have risk management review your letter. And, it can be somewhat reassuring. Just let your patients know that you're going to be following it. We're also very fortunate here where most of these patients are followed by remote monitoring. That's really important. That I think that your letter of fit should probably have something. If you're not on remote monitoring, then try to get on remote monitoring.
Absolutely. So probably finally, I want to take advantage of the fact that you three have an incredible insight that most of us electrophysiologists don't have. And I want to ask you, I know that HRS has collaborated with global heart rhythm societies and industry partners on this alert. Maybe you could lift the hood on how that happens, and how is the estimated scope of this particular alert different to advisories perhaps that we've had in the past, and what do we suppose its global impact's going to be?
Well, there,
Molly,
yeah, go ahead.
No, I was thinking maybe Molly could discuss the rapid response safety alert team and how that process works.
Yeah, I think so. So HRS, we've had this rapid response team for quite some time, where any type of advisory that comes out goes through HRS so that we can sort of then help communicate it to our members and to our physicians. So essentially the process is such that a company, whether it be Boston Scientific, Medtronic, Abbott, whomever, ablation companies, if they notice that there's a problem with one of their devices or some of their equipment, they do a deep dive, they do their own research, they try to figure out what the problem is, what the root cause is, what the scope of the problem is going to be in terms of physicians and patients. They work with the FDA, and they sort of develop sort of their own thoughts and their own guidelines. After they do that, they then come to Heart Rhythm Society, and we meet with the companies. Usually we meet with their lead engineers, we meet with their sort of people who are in charge of that service line. And that's a great time for us to ask them questions and for all of us to sort of communicate what might be going on, how this might impact physicians and patients alike. After that process, we then create the alert, which is then disseminated to our members. So that's sort of our process. When you're dealing with an alert of this size, where it's not just, certain devices and one manufacturing plant, we see those alerts too, but they're really, 250,000 leads implanted in the US or 350,000 globally. That's when it becomes very important for Heart Rhythm Society to work with our global partners. And we did that this time. We met with European Heart Association and some other heart associations internationally over Zoom to ensure that we were all on the same page about what matters here and how this impacts physicians and patients and patient care. And that's kind of where the process sort of goes. We also met with the FDA ourselves individually to make sure that we were, again, on the same page with all the stakeholders in terms of what to do with this specific alert. So that's kind of our summary of our process. It is a very rapid process. I think we got alerted on this on a Friday morning. We all met at like 6:30 in the morning. And then over the course of the next week, met with some of the other global partners before we were able to communicate this out to the membership. That's how we do it.
Fascinating. Well, thanks for doing it. I think as a
our pleasure.
practicing electrophysiologist, I'm glad that you do. So finally, Dr. Chung, maybe I could ask you, just to summarize, what key takeaway or takeaways would you like our Heart Rhythm Society TV viewers to remember from this particular advisory?
I think for these leads, we need to pay attention to the impedance trends. And I don't think, we that may not have been high up on our radar before. And that kind of do a visual 28-day, 1 month, scan across the impedance trends. And if they reach 70 and 90 ohms, then program everyone to initial polarity. If you can't, then you start having to have these discussions. And if you get to 150, then consider lead extraction or replacement or some other management. So hopefully this clarifies it. I know when we were talking to some of our global partners like EHRA, there were different levels of interpretation of that figure 1 in terms of levels of concern. I think we came to a consensus and harmonized recommendations, and that's been the best part of this, was the collaborations that we had, and to be able to bring clarity to a very complex advisory. It took many meetings for us to bring this clarity to you. So thank you.
And just for another thing that I do want to add to that, I think it's one of the other things that we did, and we do this with most advisories, what we did specifically well with this is clarifying sort of what is the process with Boston Scientific for patients who are impacted in terms of out of pocket costs. And that was kind of a huge win, I think, for Heart Rhythm Society and our global collaborators, to ensure that patients who are impacted are less impacted by the financial issues because of the work that we did.
I think that's a remarkable example of the advocacy that Heart Rhythm Society does for our patients, and I'd like to thank you for that. And thanks to all three of you for joining us this evening. More information, if required, is on Boston Scientific's website, also on the Heart Rhythm Society website. If you go to the home page, and then publications and resources, and then in the resource library, there's a excellent summary of a lot of what Dr. Chung presented earlier on. Again, I'd like to thank Dr. Sachdev, Dr. Chung, and Dr. Shanker for your time this evening, and I wish you well.
Thank you.
Thank you, Oliver.
Thank you.